So heart failure is a syndrome of effects. Anytime you hear syndrome, that means it's not one thing. It's several factors that contribute to it. A syndrome, progressive inability of the heart to pump enough blood to meet the needs of the body. Progressive, right? It's not just, it continues. Once it starts, it becomes almost like a cascade of affairs, and so many things starts going wrong. Right? There's a lot of complications that go with it. So it used to be called congestive heart failure. Now they want to call it just heart failure because it's so many things that contribute to it. So it's not only because of congestion, right? It could be that thickness of the heart muscle that it's no longer, able to pump. So it's a group of activities that result into it. So coronary artery disease, right? Arteriosclerosis, hardening of the arteries, the plaque buildup. Coronary artery disease is an example of what can lead to heart failure, right? We did have that picture here where we have that narrowed artery resulting into low cardiac output, right? Now, we have low cardiac output, and we said it is associated with low oxygenation. Then there has to be a compensation because I don't have enough, right? My arteries are so clogged, not getting adequate oxygenation. The body automatically will have to compensate. There has to be compensation. That's what happens. And then eventually the compensation fails. So compensation is only a temporary thing, just to meet up with the need. And compensation means that the heart will now have to work overtime to meet up with that deficiency. So it's overworking of the heart because compensation increases the heart rate. The heart now will be pumped a little harder, a little harder, a little harder to meet up with the demand. Then that thing, you remember sometimes you have a child and the child runs away from you and you start running? You're gonna get tired. You can't run. If that child wants to run to the next town, you're gonna get tired, right? So that's what happens when the heart starts compensating. It gets tired. So coronary artery disease is one example. Now, cardiomyopathy is another thing, right? That affects the muscle, right? So it's also thickening. Remember that I said it's a contribution of a whole bunch of problems, right? And we said coronary artery disease is one. Sometimes, remember the valves will have problems and they have leaking, and then some chambers will now hold more blood than normal. And if the chambers are supposed to be kind of elastic, the vessels are supposed to have some elasticity, right? Something that stretches. So today we have extra volume, then it stretches to accommodate that. Tomorrow, more volume, it stretches. Something that stretches, then stretches to a point where it can't stretch anymore. Then it gets hard and thickened because of overload, overtime, right? So remember all the problems, so many things. Hypertension, too much pressure built up for overtime. The heart is working overtime with every problem, with every, anything that goes wrong. Death of a heart muscle. Remember I showed you the picture where a section of the heart muscle dies from the MI? Then there's another compensation because the rest of the, right? It's all about, if it's 100% before and we have an MI and here there's damage and maybe any other part, it's no longer 100%. It's now less than 100%. So the same thing affects cardiac output. The same thing, something has to give in, something has to suffer it. So that's why we're saying a syndrome. Several things that come together and cause problems. Heart valve disorders, right? Problems with the heart valves, they can cause leakage. myocardial infarction, they all contribute to heart failure, right? And of course, heart failure, we have the left side of the heart, then we have the right side of the heart, right? So, pathophysiology, each ventricle pumps equal amount of blood. What did we say was the cardiac output? How do we determine cardiac output? Stroke volume, right? The amount of blood ejected by the ventricle in one stroke, right? Stroke times the heart rate, right? Right? It's a function of the stroke volume times the heart rate, and that gives us the cardiac output, right? So, normally the ventricles are supposed to eject a certain amount with each stroke, right? Now, so something may happen, and let's say one of the valves, maybe on the left side, it's malfunctioning and leaking. And that means one ventricle will now suffer more than the other. You understand? So, right. So when anything goes outside of the norm, when one section of the heart, one section of the ventricle, one section of the atrium, right, starts working harder or have to deal with more volume than normal, then they all contribute to heart failure, right? So if more than either ventricle can handle, it's all about how much is a normal volume to eject with every stroke of a heartbeat. But when the left is, when there has been a myocardial infarction on the left side, and it's affecting the left ventricular wall of the myocardium, and it's no longer as effective, right? So then the other one will now pick up, because this is now meeting up. Then maybe I have to work a little harder to meet up. There's this collaboration that works there, right? And then one has to automatically compensate to meet up with the need, but then they both now get tired. Left ventricle does the most work, right? It does the most work. And then it tends to fail first before the right. Because it does the most work, which when it gets tired, then the right then picks up, and eventually they both are no good anymore, right? So failure of one leads to the other, all right? Left-sided heart failure, the left side. The left side does the most work, right? And we said the left side tends to fail before the right. Okay, so what happens with left-sided heart failure? When we talk about afterload, it's still also about ejection, the stroke volume, the stroke, the amount of blood ejected by the left ventricle. So the force generated by the left ventricle to be able to push the perfusion over to the aorta, it's a lot of force. So whatever it is, let's say somebody huge is standing in front of you, and you want to move them over, right, in order to pass through. So if somebody my size is standing in front of you compared to somebody like Cyprian, you're going to use different amount of force, right? That's what's happening here. So the afterload is whatever amount of force you're going to use to move me over, or the amount of force you're going to use to move Cyprian over. That's the way it works with the left ventricle perfusing past the aortic valve into the aorta. So it's so much rush from the systems of the body, so it's so much pressure there that it has. So it's called the afterload. Afterload, the amount of force that it takes the ventricle to push, perfuse over through the aortic, to the aorta, through the aortic valve into the aorta. Okay. So peripheral vascular resistance. The pressure within the aorta and arteria. Peripheral vascular is all the systemic, all the peripheral areas. So there is resistance. There is resistance, and resistance contributed to decrease efficiency of those muscles, decrease efficiency because of coronary artery disease, right? So this, remember, we're doing cardiovascular problems. So it is already those things that started from the time we're young, affecting the efficiency of the blood vessels. All right. So peripheral vascular resistance is another pressure that will allow adequate perfusion or not, or resistance to perfusion, resistance to blood return, right? Because we want blood return from those lower extremities, upper extremities, back to the heart, and be perfused again, and then goes again, right? So it influences. So if we have a problem in our lower extremities, right? If we have edema in our lower extremities, so it's not going to allow good blood return. So that means the left ventricle will have to work so much harder to push against it, because it's so much resistance from the lower extremities. You understand? So it does influence the afterload. It does influence the amount of pressure to exert by the left ventricle, right? So hypertension is a major cause of left ventricular failure, left-sided heart failure. Left-sided heart failure. Okay, hypertension is a major cause. Okay, the blood backs up from the left ventricle, and what suffers it? The lungs, the pulmonary system, it's very closely, it's close to the cardiovascular system. So that if we have so much resistance, that peripheral vascular resistance affecting the perfusion, right? So then who suffers it is the pulmonary, because of its proximity to the heart. So extra fluid backs up into the lungs. So this is key to understand and remember. Left side heart failure, the proximity of the pulmonary system means so much peripheral vascular resistance leaves room for extra fluid to back up into the lungs. So the key, when somebody, see the alveoli become congested because of the backup. Remember the alveoli is where we do gas exchange? There's so much fluid backed up from the cardiovascular system. They are not having gas exchange. They're congested, not enough oxygenation. The congestion goes to the beds, alveoli beds. So, and clogs it up, right? Edema can result from it. All right, edema can result. So, look at this picture. Remember this picture every time. When you get a question that asks you, what are the signs and symptoms of left-sided heart failure? Think about it now before we even do the right-sided. We've not talked about anything else. We're talking about the backup into the pulmonary beds. We're talking about the alveoli being involved, right? We're talking about edema and congestion in the alveoli beds. That means we're not getting that gas exchange or adequate gas exchange. So, what are the symptoms? Look at this person. It's the heart, around the lungs. So, signs and symptoms, respiratory symptoms, pulmonary symptoms. That's what you see. You know that when some people have congestive heart failure, you always think about edema in the lower extremity. No. That's not the left side. You understand? Mm-hmm. Always think pulmonary symptoms. It's the heart, the lungs that are suffering with left-sided heart failure. All right? Left-sided heart failure is the it goes straight to the right-sided. But let's see. I want to give you this before. I don't know why I don't have that. Okay. Here. Look at this page. That should be the next page to that left-sided heart failure. That should be the next one. These are the typical signs and symptoms of somebody in left heart failure. All right, so keep going further and further after the right-sided, and you will see it. All right. So left-sided heart failure. These are the typical signs and symptoms: pink, frothy sputum. All pulmonary signs and symptoms. Rapid respirations. Their alveolar bed is congested, they don't have adequate oxygenation. They're going to use accessory muscles of respiration. They're going to breathe like that. They have so much cough, that congestion, right? They have cough, They have pain because the alveolar beds are congested. They have a lot of mucus secreted, right? Crackles, wheezes, adventitious breath sounds. Okay, that everything about left-sided heart failure is about pulmonary signs and symptoms. That's it. The next is system. The jugular vein? No jugular distension. Yes.
Yeah, please. Accessory muscles. What do you mean?
Remember, accessory muscles of respiration, you're using the diaphragm, breathing so hard, using the abdominal muscles. Remember, we talked about accessory muscles of respiration. Don't forget any of these things because these are things that come out in the exam. You can't forget them. All right? So they're so short of breath. Now, look at this slide. This slide is everything about left-sided heart failure. Autopnea. These are the people who they can't lie down flat. They're only more comfortable when they're sitting up. Yes, Mitzi? Have a question?
No, it's been noise.
Okay, all right. So, you get it? Pay attention, it's very important. It's very important. You understand? This slide, left-sided heart failure. Crackles, wheezes, respiratory, pulmonary symptoms. That's what you see. It's not gonna see, not gonna talk about the other ones. Okay, cold, clammy skin, not enough oxygenation, that's it. Now we go back to right-sided. All right? So we said that when one fails, the other one now eventually fails, right? So right-sided, the primary cause of right-sided heart failure is because the left failed before. And now the right decided to compensate and pick up the function of the left side and then get tired too. All right, so once the left side fails, but the heart has to continue to pump because the body needs it. So the right side, picks up. The body must continuously pump blood against the increased pulmonary artery and lungs, the pressures within them. To the right side now gets tired. Right side heart failure results into cor pulmonale, which is the right ventricle hypertrophy. Right? It enlarges. Remember I was telling you something stretches and stretches and stretches, and then it cannot come back. Right? It overstretches and that's it. But then it's an enlargement of the right ventricle because of the overstretching or overcompensation having to do with the extra fluid or the extra workload that normally the left ventricle should be doing. So now the right picks it up and now it hypertrophies. The hypertrophy of the right ventricle is called cor pulmonale. All right? Because of so much pressure built into it, so much excessive stretching. So the backward buildup of blood in systemic blood vessels. Now that's where the system comes in. Because the right side shows symptoms that are systemic symptoms, systems of the body, away from the heart and the lungs. All right, so we have the jugular vein distension. And then we have the peripheral edema. All right, so these are typical of right-sided heart failure. Okay, here is a picture of the person in right heart failure. When the right ventricle fails, the right heart fails. You see the jugular vein here? Distension, systemic effects. So they have, see, those are the ones you check. Their lower extremities and they have repeating edema. You see the area? Now, what you see here, the liver and the spleen gets engorged also. Systemic effects. The liver and the spleen, the abdominal, blood vessels gets enlarged. with right-sided failure. So right-sided systemic effects, the jugular vein distension, the pitting edema in the lower extremities, the liver and the spleen engorgement. That's systemic right-sided heart failure. And that is as a result of the left heart failing, and then has to do with extra workload, right? So right-sided is associated with development of cor pulmonar, okay? And that is a hypertrophy of the right ventricle. All right, it's important. All right, left-sided symptoms you have to know. So remember I talked about compensatory mechanisms that take place, right? To meet up with the demand, to meet up with the deficit in the cardiac output. That's what compensation does. Automatically there is compensation. Automatically the right side picks up when the left fails. And that it's a cycle of event. It's a cycle. The left ventricle fails, then the right picks up, then it fails eventually, gets tired. All right, so it's a cycle of events that contribute. So we say syndrome, right? So the reason for the compensation is to meet up with the demand, meet up with the cardiac output. Now, when the cardiac output is low, the part of the compensatory mechanism is this sympathetic nervous system response. Remember, automatically it picks up the fact that the cardiac output is not efficient, right? It's deficient, it's inadequate, it's less oxygenation. Then it's like the body is anxious now, gets nervous, and sympathetic nervous system. Okay, I need to do something. The heart needs to do a little bit more, right? So sympathetic nervous system response. Remember we're talking about the epinephrine, the fight or flight reaction, and then increases the release or the heart rate. It induces increased heart rate, right? Remember the epinephrine slide yesterday? One of the hormones produced. So sympathetic nervous system response releases epinephrine. Okay. Anytime you think about sympathetic nervous system response, it is related to the fight or flight reaction. And all these hormones are released to meet up with that demand. Also, and of course, when the heart beats harder or faster, then we have increased oxygen need, right? We also have renin-angiotensin aldosterone system, that big system, antidiuretic hormone to conserve water, right? Remember we talked about that, to increase volume, right? Now, remember, the person in congestive heart failure is dealing with excessive fluid. Right? Now, sympathetic nervous system now says, I need to meet up with this. I need to release aldosterone, activate this renin-angiotensin aldosterone system. It will now conserve water. They are already congested. Do you see that?
Yes.
So I said it's only a temporary effect, but you see, it's doing the good work of beating fast to meet up with cardiac output. But the undesirable effect, it's going to conserve water and congest them more. Right? So it's a cycle of events. It doesn't get any better, it just worsens. They compensate, they meet up for that short time, then that's it. We can't deal with it anymore. That's why you say some of people who have congestive heart failure, they're drowning in their own secretions. They have so much fluid. If the left and the right fails, they have cardiac symptoms as well as systemic symptoms. All right? So the chambers now enlarge because now we're conserving water, causing the chambers to hold more than normal. And then the chambers get tired and enlarge. Stretch, and the stretch does not go back. It's hypertrophy. It's called hypertrophy. Increasing the muscle mass, right? And that means when it is that muscle, the myocardium, when it stretches, when the chamber stretches and holding more and more, it's not going to be 100% efficiency anymore. It has to do a lot more work, right? So increases cardiac oxygen need. So because of the congestion, a person in congestive heart failure or heart failure can easily go into pulmonary edema. So much congestion, so much fluid there can lead to edema, swelling of the pulmonary system. So the complication of congestive heart failure is that they get into pulmonary edema. So severe congestion, more and more congestion in the alveoli, very life-threatening, right? They will be drowning in their own secretions, yes.
That's for life. Yeah, that's life.
Okay, remember, okay. It doesn't really matter, but left, you're not mixing it up, the left has congestion, pulmonary congestion, and they have alveoli congestion. That can lead to pulmonary edema. Now, the right picks up when the left fails, and compensation sets in, and the body conserves water. There's more water in addition to what they have in their pulmonary system. It also will lead to pulmonary edema because they have so much fluid. All right, they can't deal with so much fluid. Remember, systemic, they have edema in the lower extremity. They have poor peripheral vascular resistance, poor blood return. They can't come back. Poor perfusion, poor gas exchange. That's it. It doesn't get any better. It worsens.
Cause and is it left-sided?
So no. Left-sided, yes. Right-sided, yes. They both fell. Nothing is working. Now, take it this way. The complication of heart failure, whether it's left or right, they get into pulmonary edema. And remember, the left side, if the right has not failed, the primary cause of pulmonary edema is the left side, when the right is still good. Now, compensation automatically sets in to have the right side pick up the effect, the function of the left side. Then the compensation continues by activating sympathetic nervous system, and then it will now release the aldosterone angiotensin, and it conserves water. The vasculature has more fluid, more volume. Then that can also contribute to pulmonary edema. All right, they're drowning in their own secretion. It's life-threatening. All right, so pulmonary edema, this is the symptoms. It's also the symptoms of left side failure. All right, left side failure, these are typical signs and symptoms of left-sided heart failure. And it's the same as pulmonary edema too, the effects that you see when somebody is in pulmonary edema. All right?
So why does, if the right side's picking up the left side, why does the right side have to take so much water with it?
No, it activates the sympathetic nervous system response, which is the flight or flight reaction, which is what? The epinephrine, right? That's a hormone. And not only that, it activates the renin-angiotensin aldosterone system. And remember, we talked about the hormones for the cardiovascular system, right? Epinephrine, aldosterone. Remember, it's AMP, natriuretic peptide. AMP, like all those hormones. So the aldosterone controls sodium, potassium. Right, so then it will cause retention, water retention. That's what happens. That's why we say it's only temporary. It's only for a short time, and then the problem will now be heightened.
It just stays there, the water just stays there.
Yes. All right, that's what happens. So diagnosis, they're going to do X-ray, right? X-ray will show them the pulmonary system, right? If you have congestion, right? We show infiltrates, right? We look at the X-ray films, ABGs, because we're having problem with so much congestion, so much pulmonary problems, right? So we want to look at their ABGs. How's their oxygenation status? All right, so we do ABGs. Remember what you do when somebody draws blood? What do you need to do? For ABG, arterial blood gas. Pressure, you wanna put pressure. It's usually very painful, right?
Straight to the left.
Put pressure for 5 minutes and it goes, they put it in what? In ice and straight to the lab. You don't wait, right? Pulmonary pressures. They can look at the pulmonary pressures, the pressures built in within those areas, right? By hemodynamic monitoring, right? They put a line, they check the pulmonary pressures. Therapeutic intervention. It's life-threatening, so immediate treatment is warranted. Remember people who have congestive heart failure, they have exacerbation of their heart failure and they come in because they're like drowning in their secretions. Even their usual Lasix dose that they get at home is not doing it. So they have so much congestion, so much shortness of breath, right? Okay, so they come in, you want whatever they can do to reduce the workload of the heart, to reduce that, having to work so hard. Whatever is the underlying condition. Now, remember we said syndrome of effects. Different things contribute to heart failure. Could be hypertension, could be coronary artery disease, right? Could be, valvular problem, whatever it is. So it's saying, look for the underlying condition. Is it uncontrolled high blood pressure? Is it the coronary artery problem with high cholesterol and all those things? So it's saying, treat the problem. Is it the angina? Is it the MI that they have that is affecting the different sections of the heart muscle? Treat the underlying problem. If it, give medication. If they're not compliant or medication is not working at this time, treat, immediate treatment, right? Treat underlying problem. You need Fowler's position. Remember we're saying autotomy? You can't lie down flat. You need something that will help expand the lungs. So Fowler's position can help so that when they breathe in, it can expand better. When they're lying down, it limits expansion, right? Oxygen and mechanical ventilation. They may need to be mechanically ventilated. Maybe when you check their ABGs, it may not be anything good, right? So they may need to be intubated. When their suffers cannot do it anymore, they may need to be intubated just for that time, and they can win them off too if they get better, right?
Remember I said pink fronted sputum, they often have some pain when they breathe in because of those congestion in the alveolar bed. So they can get morphine B. Remember, somebody who doesn't have adequate oxygenation, what's going to happen to them? What would you see? They'll be what?
Hyperventilating?
They can be hyperventilating from confusion, right? So even that makes it even worse because
More oxygen demand from the heart. There's more demand for the heart to beat up. They're so restless. So they give them morphine, it relaxes them and helps with the pain. Now, remember, morphine can depress respiration, right?
So you want to watch your patient, right? You want to monitor the patient. You want to, maybe they may need that mechanical ventilation. Diuretic. This is the time they're going to give them. If they've been home and they have a diuretic PO, then they may need to give them IV. It's that dose of, Lasix IV or whatever IV, right? Diuretic IV. And then they have the inotropic agents. Inotropic agents that help with contraction of the heart. Remember, we said hypertrophy, and it is increased muscle mass of the ventricle, and it's not effective in the pumping. And we also said maybe somebody who maybe MI, and we have some sections of the myocardium that is had the infarction. So then they give these agents. They help with the contractility, improve contraction.
Shots.
Right. Okay. And then vasodilators can also help. Right. So these are some of the medications. Nursing diagnosis, impaired gas exchange. I have some. I have some. I think I'm almost done.